right. Well, hi, everybody. Welcome back. As always, we love to know who's with us. So as you are joining us, please stick your name and where you're from and what you do into the chat. It helps us to know who's here with us today. And, is it clinicians or navigators or who we're talking to? So feel free to toss your info into the chat for us. I am so excited to be back here to talk about precipitated withdrawal again. It was like our hottest topic, and we're really happy to do a deeper dive into it. Dr. Trotsky couldn't be here just yet. Hopefully she'll be able to join us later, but in case she's not, I'm still here with Dr. Pilar. We'll go ahead and do our little disclaimer, which is that we, California Bridge, are part of the Public Health Institute, and everything that we do is through funding from CDPH. We can go to the next slide. Oh, awesome. Love having our nurses with us. Thanks for being here today, Debbie. If we could advance to the next slide, ladies. Great. And then if the next one tells you, please, if you like these trainings, join us for our Navigator Focus series, which is going to be, the next one is Mental Health and Trauma-Informed Care on April 28th. So with no further ado, we'll go ahead and jump right on into it and get started. So in our sessions, these emerging trend series, we've mostly been focusing on fentanyl related issues. And oh my goodness, every single time, like the hottest thing that pops up in all these questions from everybody, right, is about precipitated withdrawal. And so we already did a 30-minute session about general things about precipitated withdrawal. If you missed that, go back and listen to it or watch it. But what we got from you was, can you go through some examples? Can you explain this to me? Like, I'm still really uncomfortable about it. And so I invited back Dr. Pilar because he was so awesome the first time about it. And do you want to introduce yourself to everybody?
Good day, everybody, wherever you might be tuning in from. I'm Ed Pilar. I am from Arrowhead Regional Medical Center in San Bernardino, California. I'm emergency medicine trained and boarded from Loma Linda University when the earth was cooling. I continue to be, I work in the ER as an attending at ARMC. I'm also board certified in addiction medicine, where I run the county MAT bridge program in a community clinic, as well as the local county correctional institution. And I am privileged to be here. Thank you.
Not a very busy guy at all. You guys, no, I'm just kidding. Thank you for making time.
It's a load worth lifting, you know.
Awesome, yeah. So in case you missed that 30-minute session that we did about precipitated withdrawal, a couple of important take-home points that we covered that I just want to make sure everyone here knows. The first one was, most of the time when people talk about fear of precipitated withdrawal, or that they've seen it or they experienced it, what we were actually talking about is untreated or incompletely treated withdrawal. True precipitated withdrawal is very rare. So when we talk about that in these cases, I want to remind everybody, this is not a common occurrence. And when it does happen, it's okay. All right, it's okay. Don't be afraid of it. We're going to help you. Secondly, remember that withdrawal is not always perfectly smooth and painless, right? So getting worsening symptoms or not feeling great in the process can be normal. That's not precipitated withdrawal. Finally, the treatment when you do need it is bup and more bup. Bup and more bup. Give more buprenorphine. Get yourself out of it with more buprenorphine. Eventually, you'll get there. And it often can be helpful to give a dose of a benzodiazepine like Ativan or lorazepam upfront. Those were our main take-home points. So we're going to dive right on into a case and just see what questions come up. Feel free to, as always, share them in the chat with us, and we'll see if we can incorporate them today. So let's talk about, like, okay, maybe Ed, let's say like a guy, maybe a 45-year-old guy comes in, initially he was seen he's here for withdrawal. He was pretty upfront about it. He saw the awesome sign in your lobby that said, are you here, for opioid use disorder? Do you want help? And he says, yeah, I've been using like 2 grams of fentanyl a day for months. And my last use was yesterday morning. And now I feel terrible. And you look at him and, like, clearly he's not feeling very well. There's some obvious objective signs of withdrawal. It's a pretty easy kind of slam dunk case. Then it's a busy day in the ER. So you do the right thing and you say, okay, go ahead and give the patient, 8 or 16 milligrams of buprenorphine. And then we'll get him in a room when we can't. But your lobby's really full, and like the nurse took a verbal. And then while you were in the back, because a code came in, the patient's waiting and they didn't get the bup right away, and he's getting worse and he's in a lot of pain and he just wants to be out of pain. So he sneaks off to the bathroom, and the patient's like, you know what? I'm just going to use a little bit because this is terrible. I cannot wait. I want the treatment, but I need to do something to help myself. Uses some fentanyl, comes back out. Now it's a different nurse. So she doesn't know how he looked before, pulls him into a room, gives him the buprenorphine. Finally, he gets into a room, and now the nurse comes to get you because she says, hey, this guy in room 8 has really bad chest pain. And so you go in to see what's up with the chest pain, and there he is. And he's sweaty and agitated, in a ton of pain, obviously miserable, and looks way worse than when you first saw him. What is this? And what do you do as the clinician?
Yeah, so like that happens more than we know. And it to me, it points to the importance of a connection with the patient, or as Rebecca likes to call it, Verbocaine, which I think is a great term for that. Because the first thing that I got to try and do is establish that connection and trust back with the patient, and allow him to give me the permission to give him more of the same medicine that he is convinced caused us to put him into withdrawal. And again, if there's a couple of just talking points or take-home points from this series, it's connection is greater than communication, more important, and bupe, and more bupe, and more bupe. That's the take-home point. We just reviewed a case, our COE group, where a patient received 60 milligrams or so of buprenorphine during his ED course, and ultimately like 80 milligrams of buprenorphine within the first 24.
Buprenorphine. Wow.
And safely, and came out on the other side much better, back into the bridge program, and so far so good. But there's really no upper limit that we know of. And as you have heard us say in the first webinar, that we have cases of 40, 50 milligrams of buprenorphine and above.
Wow.
So more buprenorphine, and sometimes I find a little tincture of benzo in there to help with the secondary anxiety that goes along with that.
So you go in, you see this guy, and first thing you're going to do is the Verbocaine. Talk to them, say, hey, what happened? Figure it out, and then say, I need you to trust me that we're going to get through this, right? And all that language you talked about in the last conversation that we had in this series. And then maybe you toss in how much benzodiazepine are we talking? What kind of dose are you usually giving?
I'll tell you, well, depending on how symptomatic clinically they look, if like this guy, by this description, 2 milligrams.
Okay.
He's in a monitored situation. And I always reassure not only the patient, but the staff, because sometimes you get the pushback from the nurse. Oh, we're not used to giving all this medication together. What the combination? And I said, listen, if something's going to happen, if something happened to this patient that's going to be bad, I want it to happen here in front of me.
All right.
Right. So monitored situation.
Yeah, exactly. So we give 2 milligrams of, say lorazepam or Ativan, common brand name. And then you already gave the guy, say, 8 milligrams or 16 milligrams to start. What's your starting dose with buprenorphine in a patient like this who's actually in precipitated withdrawal?
No less than 16.
16 at least.
So, yeah, or 20, sometimes 24. One potential issue would, this stuff tastes terrible. If you talk to your patients, you will learn that it's not very. It doesn't have a good, and it can induce nausea.
It's not an Altoid.
So, I've had patients where I've given them a big dose, and then I come back to see them, and here's a half digested or dissolved tablet on the pillow because their nausea is so bad. So I'll start with 16, but I'll tell the nurse, pull another 16 because we might be giving this patient another 16 within 30 minutes or so.
All right. So 2 milligrams up front of a lorazepam Ativan type medication. Start with 16 buprenorphine, very low threshold for hitting another 16. And you're just going to titrate yourself out of it, it sounds like.
Exactly. Right.
Okay.
Yeah. And I have to keep, again, that Verbocaine, that connection. You need to allow me to give you more of the medication you think made you worse. But we've seen this before, and we know how to get you out of it. It's that kind of confidence that helps deepen that connection and trust with the patient.
Right. And so I think also being able to explain to them, you know, that medicine that we already gave you that's in your system is not going anywhere. Right. It's stuck in there. And so the best thing we can do is actually give you more of it to get you feeling better, because we can't, you know, taking more fentanyl isn't going to fix your problem right now. You're going to stay feeling like this.
Yeah. And sometimes I don't try and get too granular in the pharmacokinetics, but I'll say this medication is actually knocking off the fentanyl from your brain receptors and protecting it. You know, to give them a little visual that, you know, what I need to do is saturate your brain.
Right. We've got one of our guests, Gilmore Chung, put this amazing analogy that I want to share with the group, because I think we could all learn from this. He'll use the verbiage to patients. He'll say, this is kind of like when you jump into a really cold pool and right away you feel terrible. But if you get out of the pool, you're just going to get more cold. But if you swim around, you will get warmer. You will feel better. That's very, very similar. That's a wonderful analogy. Thank you for sharing that with us. I'm going to steal that language.
Yeah.
That's awesome.
I think I will too. Good.
So far it sounds like in most cases, we're talking a little lorazepam, little benzo to help get through it, a lot of connection, talk to the patient, recheck them. This is not somebody who you forget about for 3 hours, right? We're stopping by,
Correct.
How you doing? Making sure they're okay, maybe adding an anti-nausea medication because that flavor is kind of blah. And don't be afraid of the buprenorphine. Start at 16, maybe even 32, you know, get yourself up there fast. Now, I mentioned this in the chat earlier, and Dr. Pilar mentioned this too. COE stands for Centers of Excellence. We have a series of hospitals within California Bridge who are just really comfortable doing medication for addiction treatment and are kind of cutting edge. And they meet regularly to collaborate and talk about what those experts are doing in their practices so that we can learn from them. And in some of their recent visits, I know that you guys are talking about some more complex cases. So let's say that this stuff doesn't work. I would say this is probably the end of what everyone agrees to, right? Is more bupe, more bupe, more bupe. But what other options are there? What are some things that our COE teams are doing and kind of, you know, testing that maybe have shown some promise? What are you guys doing out there?
Well, we have a saying in emergency medicine that everything gets better with ketamine. So that would be that's right. That would be the last bullet point that I would put on our list. Connection is greater than, you know, much more important than communication. Bupe and more bupe, and then ketamine.
Okay.
And I was kind of raised on ketamine back in my training at Loma Linda. So I'm very comfortable with that. And I think the more you familiarize yourself with the mechanism of how it works, the more you'll understand why. But there are many reasons ketamine works. And we're talking low dose, 0.3 to 0.6 milligrams per kilogram in an IV infusion. But as an NMDA antagonist, which is one of the prominent excitatory players in the GABA system, it actually decreases opioid withdrawal symptoms independently of that mu receptor. That's huge. Then it synergistically potentiates the bupe receptor signal. It reverses this fentanyl-induced desensitization that fentanyl has on the mu receptor. It inhibits this descending hyperalgesia pathway, and it also has a very potent antidepressant effect.
Huh.
And I don't know if this is a good time to reference the article.
Yeah, do it.
That we're just going to have our participants put in the promotion code to get the art. No, I'm just kidding. But Andrew Harry, our fearless leader, one of them, our fearless leaders, was involved in a study that has been recently published. It is an excellent article, and it speaks to exactly what we're talking about today. So, and it has a great description of ketamine's mechanism and explanations as to why it works.
Yeah, let's talk a little bit about the dosing. So I feel like for myself as an emergency doctor, I'm very familiar with ketamine. We love ketamine. It works in so many different patient scenarios, in part because, like you said, it does work on the NMDA receptor, which is a receptor that we don't often I would say, like use in medicine. It's kind of a unique thing, just sitting there waiting to be activated, to be helpful in a lot of situations. So I think a lot of people are familiar with like the 2 milligram per kilogram IV sedation dose, right? Which is also a 4 milligrams per kilogram IM, intramuscular sedation dose. What kind of dosing are we talking about though in this situation, in a precipitated withdrawal? What dosing are we talking about?
Yeah, probably at 0.3 milligrams per kilogram.
3
That's
mg.
the starting point. Yeah.
That's
And it could be
so
and
higher.
It could be 0.3.
0.3. I was like, whoa, yeah,
0.3.
0.3.
0.3. Yeah. And that could be redosed.
How often?
So you can do it with, usually you'll know within the hour or so. It'll take a while for that drip to go in.
Yeah.
And at the same time, you can continue to add bupe.
Right.
So it's not a serial process as much as it is a parallel process.
Yeah. So there were some questions in the chat about that. So let's clarify. So we see the patient, we give the lorazepam, we give maybe 16 milligrams of buprenorphine. And are we still on the Q1 hour recheck for bupe dosing? Is that still our schedule? Is every 1 hour?
Well, if I feel like someone is in accelerated withdrawal or precipitated withdrawal in this case, which would be rare, as you mentioned, I'm checking on this patient every 30 minutes. Because my experience, I'll tell you right now, my experience is these patients require lots of that Verbocaine. You have to continually be reassuring. And I'm telling you right now, as I will never know what it's like to be in that kind of withdrawal, right? And I would, so these people are at high risk for elopement.
Right.
And they really have to be talked down and reassured.
Yeah.
So often, because of stigma, we often like to treat nurses. Sometimes will put them in a corner and just kind of go on. And then next thing you know, you go back to see them and they're gone.
Right. So this is similar to what I think we often talk about with culture shifting and thinking about withdrawal, is that this is a medical emergency. This is a person in an acute medical emergency. And especially if you're hitting precipitated withdrawal, if that really does happen, it is rare, just like all of the super high acuity other presentations, right? Every patient is not a code blue, but when they happen, they really need your attention. I think that's what I'm hearing from you, is a true episode of precipitated withdrawal. This is a resuscitation. It's a bupresuscitation, right? Like we're going to check on them every 15 to 30 minutes, keep going with the buprenorphine, Q 30 minutes until they're getting better. Don't be afraid of like 16 milligram doses on top of each other. And maybe adding that ketamine if the person really is sick and not doing well. Place that IV, get that ketamine.
I find exactly. And I find myself being more in the patient advocate zone when this happens, because I find myself having to spend a lot of time mobilizing the care team around this patient, say, this is what's going on. We need to keep eyes on this patient, and you come and get me immediately if they start talking about wanting to leave, that kind of thing.
Yeah.
If I'm not proactive with that, like that, I often find that they will elope.
Yeah. So let's talk a little bit about methadone, because this question comes up a lot. I feel like every time people talk about precipitated withdrawal, they'll say, well, what if I ask the patient they use methadone? They say no, but they didn't know that they did, or they did and they didn't want to tell me, or whatever. And I think I remember you telling me there was a case of a patient on methadone that wanted to be in treatment and decided to start Suboxone at home. And so that kind of launched them. And so talk to me a little bit about what to be worried about with methadone, or how that might change any of this.
Right. I'm going to go back to connection, because I have learned in all my years that there's nobody more disappointed in this patient than themselves. Yeah. So if I don't have that connection with them, then they're not going to be honest with me. And it takes a little extra time, and saying that within a busy emergency department is like heretical, because we got to move these patients in and out. So if that happens and there is information that wasn't disclosed and they end up admitting to methadone, it really doesn't, the pathways, all roads converge to bupe and more bupe is the take home.
Right. I mean, bupe is, we know bupe is stronger than methadone too, right? So if it happens and we now are seeing precipitated withdrawal, keep going.
Exactly. And you know, if you take the time to speak to patients overall and learn from them, they will tell you that the methadone kick is far worse than a typical heroin or fentanyl kick.
Right.
So they are going to be, you know, supremely miserable.
Yeah.
And they might take a little bit extra of that Verbocaine.
Yeah. And that
to help keep them engaged and connected in their treatment.
Yeah. There was a question in the chat about getting any pushback from pharmacy with higher doses of bupe. Gloria, for that question, I would say, of course, you're going to see that. That does happen. So that's why we were always encouraging sites like to do education and include your pharmacy. And then make sure that your clinicians are prepared to talk to that pharmacist on the phone and say, actually, I'm not doing regular withdrawal here. This is a resuscitation in a precipitated withdrawal patient. I know what I'm ordering and I do mean it. And to be able to have that conversation is going to be really important. So education, you gotta educate your way out of pushback most of the time.
Yeah, and you should expect that.
Yeah,
because there are going to be multiple layers of knowledge, and this is a cutting edge practice, right?
Yeah, we didn't used to give a lot of bupe, so we didn't have precipitated withdrawal.
Well, yeah, exactly. And the drugs that are on the street, they're not your daddy's heroin.
Right. You
know,
and what I would also throw out there, though, I mean, we talked about this in the first call we did about, or the first session we did about precipitated withdrawal. But remember that, like I just said that we didn't used to do this. We actually did. Remember that giving naloxone, giving Narcan is precipitated withdrawal on purpose. That is what we're doing, is putting somebody into withdrawal. So in reality, we actually do know what this looks like. And it's not dangerous or life-threatening. It's just painful and horrible for the patient. And so what we're trying to do when these things happen is we're trying to get them comfortable and into treatment out of that. So I shouldn't have said that we never used to do it. What I meant was we didn't see it from starting treatment, right? That was different. But I do want to throw out a case. So I actually had a case in my own network where I got a phone call, and I wanted to talk it through with you because I think that this is way more common, one of the more common examples also. So there was a woman, a 26-year-old pregnant female, actually. She was in her third trimester, and she came in and was admitted to the hospital related to some pregnancy stuff. So it wasn't for anything substance use related. And she uses fentanyl. It had been about 12 hours since her last use. And she started going into withdrawal, into having symptoms of withdrawal. And I will say, like, the obstetrics team, I think that sometimes they're not quite as adept at this as our emergency departments are. And so they felt very uncomfortable with buprenorphine. And so they called like a local expert, and that person advised them to try micro dosing. And they started her on these little bitty baby, like 2 and 4 milligram doses of buprenorphine. So over the past 8 hours, she had not even received, I think, 6 total milligrams. And now she's like agitated and angry, and like and everyone's labeling her as non-compliant. And the CPS worker is literally going to be here in 2 hours to talk about custody issues because they know that she's screened positive on a drug test. And everybody's yelling, she's in precipitated withdrawal because we gave buprenorphine. And so that's how I ended up on the phone. Was the substance use navigator called me and said, can you help me fix this? What is going on? And they were calling it, quote, microdosing, right? That's the term that we throw around. Tell me what's actually happening in the situation and what would you do?
Okay, here's another bullet point. Microdosing equals underdosing.
Yeah.
So having said that, now we're talking about, again, a person that's already in accelerated or on precipitated withdrawal. So that in my world, that state of withdrawal, there's no room for microdosing.
Right.
Again, we got to understand buprenorphine. We all know it has a higher affinity for the receptor, but it has a lower signal. So we have to saturate that brain. And you know, our OB colleagues mean well, but they've lived in the methadone era for a long time, and that's what was kind of the standard of care for OB. And we've slowly been able to change that. But it's once again, it's a high dose bupe treatment.
Right. And so this is not precipitated withdrawal. This is grossly undertreated withdrawal under the guise of, quote, microdosing.
And it's safe. It's safe in pregnancy. It's safe for baby. It's safe for lactation, and we have evidence that there's less of it's less it results less in fetal abstinence syndrome.
Right. So we know bupe is safe and effective, but we got to treat our pregnant patients the same way that we treat our normal patients and not be afraid of real doses of buprenorphine, right? So we've just been talking about how some of our patients with really high fentanyl use, 2 and 3 gram use a day, they end up on like 32 to 64 milligrams daily. So you can imagine you've got a patient in the hospital setting who's getting 4 milligrams, maybe 8 milligrams over hours. That's not even close to being what that patient needs. And easily, I think because of fear and what we hear, people will call that precipitated withdrawal. They'll be afraid of it, but that's not what it is. And this is actually a great example of what we see way more often. When someone says the word precipitated withdrawal, they're talking about a situation like this, where what they mean is the person is now just in really bad withdrawal, and maybe they got some bupe, so everyone assumed it precipitated, but really it's just getting worse on its own, as if you gave nothing because it wasn't enough. So that's a really important take home, I think.
Right. And then, and lastly, if I could add, Ativan, feel free to add Ativan to that cocktail or that treatment plan.
Yeah. And there's a question in here about like, but if it's only been 12 hours, what do I do? And again, the answer is you got to go with your patient. You got to look at your patient. How bad is their withdrawal? What's their COWS, right? We recommend 8 or higher for that score to be able to start it. However, in fentanyl, what we've told you is wait a little longer, more like 10, 11, and with objective findings. And the patient we described to you, maybe their last fentanyl was 12 hours ago, but this woman is in withdrawal, right? She's in very clear withdrawal. Don't be afraid to treat the withdrawal. There's no timeline that's perfect,
And if I could remind everyone again, objective signs of withdrawal.
Yes.
Objective. Pupils,
help
skin,
just to
sweat,
help recap.
tachycardia.
Sweat,
exactly.
tacky, dilated pupils, goosebumps.
Don't score restlessness or anxiety or the subjective. So
In our closing minutes here, the last question I would ask you to share any advice for when you're counseling patients about self-starts. We just did a nice long 30 minutes about self-starts, but if you're concerned about precipitated withdrawal or the patient's concerned about it, is there anything special you tell your patients when you counsel them about starting bupe on their own at home?
One question I found to be helpful for me is I will, again, in the spirit of this connection with the patient, have you ever put yourself into withdrawal by mistake in the past by taking a street bupe, because you know it's out there, right? It is keeping people alive, and if they say yes, then I know that I'm preaching to the choir. And then I'll just walk them through the self-start. There's a great self-start protocol on the California Bridge website. The resources that I'm looking at right now on the screen for everybody's edification, and I will often share that with the patient. Yeah,
perfect. So to recap our big take-home points, and again on the screen here shows you how you get to our resources page where we have everything we've been putting in the chat for you. So feel free to go here and use any of this, including our newly release an improved version of the quick start guide with some tips about fentanyl and dosing, how you might adjust it, and see this cute little box in the corner about how to treat precipitated withdrawal. We added that to our quick start guide because this is just a thing you should know about, but not fear. So remember that most, quote, precipitated withdrawal is not. It's undertreated withdrawal. Don't be afraid to give buprenorphine. If it is precipitated withdrawal, number one most important thing, connect with the patient. Be honest with them. Talk them through it. This is an emergency resuscitation. It's rare. It's a resuscitation. Give bupe and more bupe and more bupe every 30 minutes or so until the patient starts looking better. Don't be afraid of higher doses. Remember, it's not going to cause respiratory depression at the doses that we're talking about, but you monitor the patient, you watch them. Add that 2 milligram oral dose of lorazepam to help them get through it. And if it's like taking a longer than you wanted it to, and the patient's really agitated, consider a dose of ketamine, 0.3 milligrams per kilogram IV. There's also intramuscular and intranasal doses, which you can look up, but all that's accessible to you. And as always, right, we always talk about this, connect with your patient. Like that is how we save lives, is by changing culture and treating these patients as if they have a real emergency, because they do. So I want to throw out the giantest thank you to Dr. Pilar for sharing his wisdom and experience with us, and to all of you for being, it was such an engaging chat. I really appreciate all the comments and the questions that were being asked in there. And hopefully we'll see you next time. If you need help, reach out to us. We're always here for you.
Be safe, everybody. Thank you.
Bye.